Greetings, everyone. Welcome to a presentation of Helping Smokers Quit, a national program just for nurses in West Virginia, Indiana, and California, funded by the Centers for Disease Control and Prevention. The speakers are Dr. Linda Sarna, Professor of Nursing at the University of California, Los Angeles School of Nursing, and Dr. Stella Bialos, President of Tobacco Policy International in San Francisco, California. Both Dr. Sarna and Bialos are nursing leaders in tobacco control and internationally recognized experts in nurses and tobacco control. Their presentation will last approximately 40 minutes, and please note that you do not need to take notes during this presentation, as the PowerPoint of this talk is available for download on the Tobacco Free Nurses website, Helping Smokers Quit page. Also, feel free to write down any questions that you may have, as there will be a question and answer period at the end of the presentation, and should you need to do so, you can ask questions on the Tobacco Free Nurses Helping Smokers Quit web pages. Now I'll turn this over to Dr. Sarna.
Thanks so much, Marjorie. Hello, nurses from Indiana. You can see a picture of myself on the top. I'm Linda Sarna in Los Angeles. Stella Bialos is in San Francisco, and Marjorie Wells is in our shop here in California. The reason that we're doing this program today is to provide nurses in the United States, but especially nurses in Indiana, California, and West Virginia who are participating in this program, the knowledge and skills to deliver evidence-based smoking cessation interventions to patients. The guidelines for providing the best interventions for patients have been available since 1996, but many nurses did not receive this information as part of their nursing education. We also want to correct some of the myths and misperceptions about tobacco cessation, and we especially want to let you know about the tobaccofreenurses.org website and the special tab for Helping Smokers Quit that we have made available just for nurses in this program. Now, Stella is going to provide you with some more information about the health risks of tobacco and the epidemic, and challenge us as to what a good nurse does. Stella?
Thank you, Linda, and hello, everybody. Thank you for joining us today. So the program is really changing what it is that a good nurse does. It used to be, and we see this on this photo from World War II, that part of being a good nurse was to help our patients smoke, to bring their comfort, to make them feel good. Now, what is part of what it is that a good nurse does is to actually help our patients quit. It's a change in the way we do our nursing, and in some settings, this is a little more difficult. Sometimes we feel bad. We don't want to talk about smoking with our patients. We don't want to upset the patients. In psych units, we still hear about not talking about smoking being part of therapy, but this is all changing. There's too much information now about the harms of smoking and the benefits of quitting. So what a good nurse does is help patients quit. What is also helping that change is the fact that the Joint Commission requires all accredited hospitals to provide smoking cessation interventions for patients with diagnosis of heart attack, heart failure, and pneumonia. So nurses are the ones doing these interventions, and the more we know about it, the better prepared we're going to be to help our patients. This slide is to remind us that as much as a lot has been done about smoking in our country, it is still the leading cause of preventable death. Almost 444,000 deaths every year are caused by smoking, all of them preventable, close to 10,000 deaths in Indiana alone. And many of us know about smoking and lung cancer. We may not realize that the majority of tobacco-related deaths are because of cardiovascular diseases. Again, these are deaths that could be entirely prevented by preventing uptake and also by helping patients quit. This is where we are as far as smoking in the United States. About 1 in 5 adults are current smokers. The number is a little higher for men than it is for women, but it's still much higher than the goals of the year 2010 of 12% overall adult smoking prevalence. Another matter of concern is, although it has been a decline, the number has been plateaued in the past few years, and we need to bring this decline down much sharply so we can actually reach the 12% overall prevalence. It's important for us to remember that actually 70% of people who smoke do want to quit. So sometimes if we hesitate to ask our patients about smoking and quitting, we have to keep in mind that 7 out of 10 people who smoke want to quit, and even those that do not want to quit, they actually expect us as nurses to talk to them about it, to talk to them and encourage them to think about quitting. This is the number for Indiana. It's a little higher than the rest of the country. About 1 in 4 adults smoke. And although we see that the number has come down a little bit, we see again, like I said, that plateau among men. It's not coming down as sharp as before. And a big concern is that it's going up a little bit among women. So something that we really need to pay close attention and start acting to help change. And again, smoking cessation is one of the ways to change that. I'm going to go over a lot of facts and numbers. Please do not worry about it. All of these have been provided to you in the toolkit you received, and more data can be found on the websites that we refer and said before. We can also have these slides on the HSQ website. But smoking prevalence in Indiana during pregnancy is still pretty high, 17%. We need to bring this number down. A very serious concern is smoking among the young adults, almost 30%. That's much higher than the adult prevalence in Indiana and much higher than the adult prevalence in the rest of the United States. And what is important to know, because we often forget to help our patients who are young quitting. We think about it, the patients that have they're middle age or have a heart attack or something like that, and we don't realize that it's very important to also help our younger patients and our pregnant patients, encourage them to quit. We also see a higher number of teenage smoking in Indiana than in the rest of the country. And we have to think about that again. The earlier somebody quits, the more successful they're going to be, the less likely to have tobacco-related diseases. We also have to remember that in addition to being an important health impact to the state of Indiana, it's a big financial impact. Over $2 billion every year are spent by taxpayers in Indiana alone to treat tobacco-related diseases. Smoke-free workplaces law, knowing what we know about the impact of secondhand smoke on health, it's very important to provide smoke-free workplaces to all people. So although there's some progresses in many cities and counties in Indiana, we still don't have a statewide smoking legislation that will protect all workers, regardless of a level of income or education, from secondhand smoke. Cigarette taxes have increased in Indiana recently, and we already know that the increase in tax has provided already a decrease in consumption, so we already know the more expensive the cigarettes are, the better. For prevention is a very important factor in preventing youth from starting and helping young adults to quit. However, all of this progress is helping against a very powerful tobacco industry that spent over $400 million every year in Indiana alone to market tobacco products. So again, over 1.5 million smokers in Indiana, a test state for new tobacco products, a very significant market. So we have to remember that there is a very powerful industry there trying to keep people smoking and to get people to start smoking. And why is it that cigarettes are so bad for us? Well, there's different compounds in tobacco smoke. There's a gas compound, a gas phase compound, and it has things such as ammonia, benzene, very harmful. There's also particles, and there's nitrosamines, which are cancer-causal, polonium, which is radioactive. It's important to remember, though, that nicotine is not what causes the ill effects of tobacco. Nicotine is what causes addiction to tobacco. So nicotine replacement therapy is not going to be, and Linda's going to talk more about it, it's not what's going to cause cancer, for example, another myth that we need to clarify. In 2004, the Surgeon General Office issued a report updating the health consequences of smoking. The Surgeon General office has been releasing reports on the health impact of smoking for about 40 years now, and the major conclusions from the 2004 report, which is the latest, show to us that now we know that smoking harms nearly every organ of the body. There's barely an organ. That's important to know because as you go about your business, the likelihood is that you will find a patient that is there because of tobacco-related disease. So it's not just the lung cancer patients who are affected or have been affected by tobacco use. We also know that quitting has immediate and long-term benefits. And that's important to know, this immediate part of it, because it's never too late to quit. Nobody's too old to try to quit. There's always immediate benefits that everybody can have by quitting. Another conclusion is that smoking cigarettes, there are lower machine-measured yields. What does that mean? It means cigarettes that are called lights, mild, ultralights, super lights. These cigarettes actually have absolutely no benefit to health, and in fact, some studies show it might even be worse. So switching from regular cigarettes to light cigarettes brings no health benefits and should not be encouraged as a method of reducing the harms from smoking. And again, the list of diseases caused by smoking keeps being expanded, and this is the list from 2004. And like I said before, most of us know about cigarettes and lung cancer. Maybe few of us know, for example, a link between cigarettes and leukemia, or bladder and kidney cancer, or reduced fertility, or osteoporosis. So like I said, for those of us working in med-surg units and other adult care, we're likely to find a patient with a tobacco-related disease that we may not even realize until now it is tobacco-related. In 2006, the Surgeon General report on smoking and health addressed involuntary exposure to tobacco smoke. Some people call it passive smoking, some people call it secondhand smoke. It all deals about the exposure to the smoke that comes out of the tip of a lit cigarette as well as from what the smokers exhale in the air. And now we know that secondhand smoke does cause premature death and disease. Not only has incredible risks for children, such as increased risk of SIDS, respiratory infections, middle ear infections, but it also has serious consequences for adults exposed to secondhand smoke, such, for example, cardiovascular diseases and lung cancer. So it's very important that we protect everybody from exposure to secondhand smoke, and separating smoking areas to non-smoking areas. For example, a restaurant that has smoking and non-smoking, it's absolutely no use. There's no benefit at all from a health perspective to do that. It's also important to remember, I already touched on the health impact, the cost impact of tobacco use in Indiana in terms of healthcare costs for the taxpayers in the state. And this is more at the individual level, particularly if we're talking with the younger smokers. They may not be as affected by the health impact of the health news. However, we can always try to remind them that they can actually have a significant savings by not smoking. So one of the things we can do to patients is, for example, to suggest that they put away every day the money they would have spent on cigarettes, or every week the money they would have spent on cigarettes. Put it on a jar, put it somewhere, put it away, and at the end of the month, they can see how much money they did not spend on cigarettes, and that's money that they will have, for example, to take the family out to dinner, or to go to a movie, or to buy a digital camera, or whatever it is that they wanted to have, and they didn't have the extra cash to do. So that's another motivation to quit, and happens to sometimes be very effective with the younger adults. This is back to that point about nobody is ever too old to quit. This was a study following over 34,000 male British doctors over 50 years, and they're trying to find out the benefits to quitting of any age. On average, they know that smokers will die about 10 years younger than non-smokers. And of those who continue, about half of people who continue to smoke in their lifetime will die because of tobacco-related disease. So tobacco will kill approximately half of its users. But what is important to know is that when you quit at about age 30, you gain back those 10 years of life that you would have lost. But even if you quit after you're 60, you still gain years of life that could be very important and very precious. So again, it's never too late to quit. There's always an advantage of quitting. And this goes back to there's immediate and long-term benefits. Sometimes immediately, 2 weeks after quitting to 3 months after quitting, you start seeing, for example, that circulation improves, lung function increase, and those benefits start, a lot of times you start to have a better sense of smell, better sense of taste. 1 to 9 months, we see that the lung cilia regain normal function. Smoking paralyzes the lung cilia, which allows for all the debris to accumulate. So that increases. You start to feeling, the smoker who's trying to quit in 1 to 9 months, you start feeling better in terms of coughing and fatigue and shortness of breath. Sometimes we hear that patients right after they quit or shortly after they quit, they complain about coughing more than they did before. That is because their lung cilia are regaining normal function, and when they gain motility, they're going to help expectorate all the debris that has been in the lungs. That is short-term, and eventually it goes away, but it's just a normal function of the lung cilia regaining motility. So it's not unheard of to smokers come back to you and say, now that I quit, I got a cough. If there's no other disease-related that could create that cough, a lot of times is related to the lung cilia regaining motility. Again, risk of cardiovascular diseases start going down, cancer, lung cancer, that's going down, and risk of cardiovascular. So the longer you stay quit, the better it is, but there's immediate benefits. This is to remind us that tobacco dependence is actually a two-part problem. There's one part that is physiological, and that's the addiction to nicotine. And Linda's going to talk about that a little bit more. For that, there's medications, but that's actually a physiological part of addiction, of the dependence. There is also a behavioral component related to tobacco dependence, and that component has to do with the fact that people are used to smoke when they get in the car to go to work, or they used to smoke when they sit down to watch TV after dinner, and that needs to be addressed as well, because that requires some behavior change. The most effective treatment is the one that deals with both the physiological and the behavior aspects of dependence. Dealing with one or the other helps, but nothing helps as well as trying to address the two parts of this problem, tobacco dependence. This is a reminder why nicotine is such a powerful substance, it's such a powerful drug, creates such an addiction. Nicotine delivered through cigarettes reaches the brain within 11 seconds. A cigarette is the most effective nicotine delivery device. It's important to know because, as Linda will talk more about medication later, no other drug will provide that quick hit of nicotine to the brain as fast as a cigarette. And then you see that only a few minutes after lighting up, we reach an arterial concentration peak, and then it goes down, and that's, of course, is what's going to let people to smoke again so they can maintain the optimal serum concentration level. And this is kind of how it works. The nicotine in 11 seconds gets it to the brain and it stimulates dopamine release. It creates pleasurable feelings which lead to repeat administration, and tolerance develops. These are the typical descriptions of an addiction, of an addicting drug. It's important to remember nicotine is an addiction. It is not just a bad habit. It's not, if you want to quit, you can. People need help to quit. Tolerance develops, which means that most people don't start out as a 3-pack a day, a 2-pack a day, or even a 1-pack of cigarettes a day. Eventually, tolerance develops until the smoker reaches whatever it is that they need to smoke to reach the optimal concentration, serum concentration level to maintain those pleasurable feelings. So again, the tobacco use will do anything to maintain minimum level, to prevent withdrawal, to maintain pleasure, to modulate mood. And sometimes how you're going to do that, you can either smoke more frequently to maintain that level. You can smoke more intensely. That means taking deeper drags of the same cigarettes. Or if you're trying to smoke the so-called light cigarettes, the low nicotine brand, you can obstruct the vents because, like I said, these light cigarettes are determined to be lights because a machine smokes them. When people smoke them, you cover the holes and you get as much nicotine as you would otherwise from a regular cigarette. Nicotine has some serious documented withdrawal effects. These are not just somebody's not being strong enough to deal with it. And a lot of times we're going to encounter patients who are they're in the hospital. Our hospitals are smoke-free. The patients are not allowed to smoke. And sometimes if we hear your patient complaining of insomnia, anxiety, restlessness, difficulty concentration, irritability, we may not know why are they feeling that way. We may think it's related to the underlying diagnosis, which could be, but a lot of times we forgot to wonder, could this be related to having nicotine withdrawal symptoms, and can we address that? It's also important to remember that withdrawal symptoms will subside between 2 to 4 weeks after the quit attempt. So it is temporarily, and you can remind your patients that it will pass. And to help with the nicotine addiction, there are several medications available, and Linda is going to discuss them with you. What is important for us to know is that having pharmacotherapy does help with the withdrawal symptoms, does facilitate so the patient can focus on the behavior modification that is necessary, and it also improves effectiveness, improve the chances that the patient will remain quit several months after the quit attempt. Linda, do you want to take it from here, please?
Thank you very much, Stella. Well, Stella has told you the bad news about the devastating health impact of tobacco use, the incredible power of the addiction. And now I want to tell you some of the good news, and that is that there are evidence-based strategies to help smokers quit, and there are more medications than ever before to help with the withdrawal symptoms. So what I'm going to do now is to go over some of these medications that are FDA approved. For those of you who have the Helping Smokers Quit, a guide for clinicians, these are detailed in the fold-out section of that guide. Again, this was part of the toolkit that you received for Helping Smokers Quit, but it is also available from the Agency for Healthcare Research and Quality with a link on our website. So one of the medications that's been available for the longest is the nicotine gum. This is a product that's really not a gum, but you do chew it and park it in your buccal mucosa, and it releases nicotine in a way that allows you to not experience the withdrawal symptoms to the same intensity. Generally, there are different doses of this gum depending on whether or not you smoke 24 cigarettes per day or more than 2 packs a day. And generally, people use this product for approximately 3 months. It is available over the counter. The second is the nicotine lozenge. This is more recently available. This is also dose-dependent upon when a smoker begins smoking after they wake up in the morning. A good way to assess nicotine addiction is to ask smokers when they first smoked their first cigarette. And if it's within the first 30 minutes, it means that they're more highly addicted than those who smoke later. This product is also available over the counter and is used for approximately 3 months. There can be some heartburn or indigestion, some irritation of the throat, but generally this is very well tolerated. The nicotine patch has been around for a while. You may be familiar with this. Generally, this also has a dosing system so that patients who smoke more frequently or more cigarettes have a higher dose. The dosage is a step-down system, so you have with 21 milligrams for 24 hours, then 14 milligrams for 24 hours, and then 7 milligrams. So this is a step-down system, and generally this product is used for 2 months, and it is both available prescription and over the counter. The nicotine nasal spray is another way of delivering nicotine, and this is prescription only. It's used for about 3 to 6 months. Patients do complain of some nasal irritation, but if some of the other products have not been successful or they haven't liked them, this may be another alternative. Now, the products that I've discussed thus far all have nicotine in front of them, and they are nicotine replacement medications. That means that they replace the nicotine that's generally in the cigarette. The next two, bupropion and varenicline, are a little bit different, and they're administered a little bit differently because they take the pleasurable feeling out of smoking. And bupropion Zyban, or the generic bupropion, is started a week or so before patients make a quit attempt. So they get up to a blood level so that they take it for several days, and then they begin to have the maintenance dose. This is prescription only. It's used 7 to 12 weeks, and sometimes maintenance up to 6 months. Varenicline or Chantix is similar. Patients start with a loading dose before they stop smoking, and then they have a maintenance dose. This is also prescription only and used for 3 months, maintenance up to 6 months. So there are lots of different options, and it can depend on what the patient is interested in, what their past experiences are. Both bupropion and varenicline have some contraindications, particularly for people who've had seizure disorders for bupropion and for patients who experience significant mood changes or have a psychiatric history for varenicline. Now, we also know that, to reinforce, nicotine replacement is used to help with the physical withdrawal from nicotine. It eliminates some of that immediate reinforcing, pleasurable nicotine that's absorbed via a tobacco smoke. And Stella talked to you about cigarette being the perfect nicotine delivery system. And it also allows patients during this interlude while they're using the medication to focus on the behavioral and psychological aspects of smoking. This next graph depicts how effective cigarette is of getting nicotine into the system and also moist snuff. And you can see that these other medications do get nicotine into the system, but they don't have the same peak. However, they all are able to help with the withdrawal symptoms and really do make a difference in terms of quit attempts. Now, the reality of tobacco cessation is that only 5 out of 100 people who make a quit attempt without any assistance, the so-called cold turkey, are able to be quit 1 year later. Very few patients adequately prepare and plan for making a quit attempt, and patients and often healthcare providers don't understand the importance of really examining the need to make a behavior change. You can't just make yourself quit. You really need to think about it, and behavioral counseling, as recommended by the guideline, is one of the things that can almost double quit rates. We know that clinicians, the involvement of healthcare providers, can make a big difference in helping smokers quit. And compared to smokers who receive no assistance at all, those who receive assistance from clinicians are twice as likely to be successful for 5 months or more. Now, the data are increasing on the effectiveness that nurses can make in helping patients quit. And this slide demonstrates that patients who receive help from nurses have a 28% greater probability of being able to be quit 5 months or more later. So nurses really can make a difference, and again, more and more research is coming out. I mentioned previously about the Helping Smokers Quit Pocket Guide. This is something that we hope you will find to be especially useful. It's small, you can fit it in your pocket, and it's organized according to the Public Health Service guideline with the principles of the 5 A's: asking about tobacco use, advising people to quit, assessing readiness to quit, assisting during the quit attempt, and arranging with follow-up after patients have made the quit attempt. So I'm going to go through these 5A principles right now. So the first one is ask. Now, we are getting better at asking about tobacco use. This is an important time to have a conversation with patients to help them understand that asking about tobacco use is very important because it might interact with their medications, it might interact with their recovery plans. We want to ask them whether any other people smoke in their household. And again, some of the reasons why they may be in the hospital might be to their related to their tobacco use. The next A is to advise, and this is to advise in a clear way that quitting is one of the most important things that they can do for their health, and that you can help them, that you can refer them to the people that can help, and especially we're going to give you some information about referral to the telephone quit line. You want to let them know that there are a number of medications available that can help with their quit attempt. Most smokers have made quit attempts in the past, so they've had experiences, and maybe they've used some medications that they didn't like, and you need to know that they're even more available now. And again, people who receive assistance are more likely to stay quit than those who just quit on their own. The next A is to assess. And when I talk about assessing readiness to quit, yes, it's important to see if they're willing to make a quit attempt, but even if patients aren't willing to make a quit attempt, it doesn't mean that you don't intervene. What you want to do is to try to discuss with them some of their reasons for being reluctant to make a quit attempt, whether they're ever thinking about making a quit attempt, what their experiences have been like in the past, whether or not they appreciate some of the benefits that they personally might get. And again, this is a way of linking their smoking to their health condition, or to understand what are the worst things that maybe they're concerned about with quitting smoking. So with all smokers, yes, you can assess whether they're ready to quit, but you can also refer even people who aren't ready to quit to let them know what are the resources that are available so that when they do make that decision, you'll be ready. Now, with assessing, assisting patients with a quit attempt, this is where ideally you want to make a quit attempt where you have some time. And in the primary care setting, in the outpatient setting, you can just have a conversation about quitting and then plan for that quit attempt in the future, a week or so. In the acute care setting, for patients who are hospitalized, they've sort of been put into a forced quit attempt. Here your conversations can be around, okay, now you're not smoking. What can we do to help you stay smoke-free when you're discharged from the hospital? This is an opportunity to discuss support from family and friends and coworkers. It's a time to review what those past quit attempts were like, what helped, what led to relapse, to have that conversation about challenges, especially during those first weeks. That's when the nicotine withdrawal symptoms are the most severe, and this is when most people relapse. You can also help them personalize their own benefits from quitting and their benefits, the reasons for quitting and the benefits that they will achieve. Now, giving the advice on successful quitting means that you may also want to let them know that complete abstinence is essential. This is what the research demonstrates, that those people who say, well, I'm going to quit, but I'm just going to take a cigarette here or there, we know that they're more likely to go back to complete smoking. So really, not even a single puff. Abstinence is abstinence. And especially, you want them not to be smoking if they're taking nicotine replacement medication, because they're going to be getting then additional nicotine, their heart will race, blood pressure will go up, and that's not a good thing. Also, you want to discuss that drinking alcohol is going to, again, be associated with relapse. So this may be a time to discuss how they might be changing around their social time. Having other smokers in the household also hinders a successful quitting, and that's why we want to have to tell you about the telephone quit line, because that's something that even family members can utilize. So when you're involved in the assisting people to quit smoking, this is the chance to discuss the different pharmacotherapy. Again, there's not one perfect drug for everyone. There are different drugs for different people, and it depends what their past experience is like, whether or not they have any contraindications, and the conversation with their physician as well. You certainly can provide them with the resources. The telephone quit line, 1-800-QUIT-NOW, is a way that they can receive the long-term behavioral counseling and support that is so essential to quitting success. There are also free materials that you can get from the Agency for Healthcare Research and Quality for patients and for healthcare providers. And the tobaccofreenurses.org website will also have materials. And there are different materials depending upon translation and pregnancy status too. If I had to say what A is the most important, once you've determined someone is a smoker, it's probably arrange, because we know that you need to arrange for the follow-up, because again, 5 out of 100 will relapse unless they have the type of support, especially the counseling and support and the use of pharmacotherapy. Since relapse usually occurs that first week after quitting, this is when you can make plans to how they're going to get the follow-up. The follow-up may be at that follow-up visit with their healthcare provider. They also can get follow-up with the telephone quit line. Now, if relapse occurs, this is not a failure of them or of the process. It is part of the process. This is a time to encourage repeated quitting, to find out what happened, to use it as a learning experience, and to maybe to reevaluate the pharmacotherapy. Sometimes patients, to save money, won't take enough of the medication, or they're not using it appropriately, so you can discuss that as well. You can also discuss other resources that are available in your own community. When nurses are very limited in time, the minimal intervention that you can provide for your patients is referral to the 1-800-QUIT-NOW number. There may be hospital-based cessation programs in your institution. You want to check that out. There might be some local groups. The American Cancer Society, American Lung Association sometimes have smoking cessation counseling groups. Sometimes some of the medication that patients will be on also provide some smoking cessation support. There are some quit line programs that are based on the evidence. Quitnet.com is one of them. But we want to make sure that you know about the telephone quit line, because this is a free and underutilized resource for patients. And in Indiana, you have the 1-800-QUIT-NOW program. You have your own quit line card, and that is in your toolkit of materials. Again, referring patients to a quit line is simple and easily integrated into routine patient care. It's effective. Many studies have demonstrated that it increases quit rates. It's provided right now at no cost to the caller. What happens is that patients receive one-on-one coaching and counseling and follow-up from trained counselors. They receive customized quitting plan and materials. The callers are encouraged to contact their physicians for smoking cessation medications, and sometimes there's some additional rebate or support that the quit lines can help you with, and also for referral to some of the community programs. There are numerous resources in Indiana that you can find out more information from the Indiana Tobacco Prevention and Cessation resource through the websites that we have here. The good news about the Indiana Quit Line, and this really is good news, is look at the availability. It's available from 8 a.m. to midnight, 7 days a week. So it's available at times when patients can contact them regardless of what their work schedule is as well. Some hospitals even have fax referral systems where smokers can get in touch with the Indiana Quit Line while they're in the hospital so that they can begin right away getting the support that they need. What we've provided for the nurses in this program as part of the tobaccofreenurses.org website is the HelpingSmokersQuit.org website. But this is only available to nurses, again, in California, Indiana, and West Virginia. And you need to type in your password and your username, HSQ, in order to get access to those materials. So, why should nurses in Indiana address tobacco use? Well, we hope that we've convinced you it's one of the most important things that you can do to protect your patient's health. That if each of the over 1,000 nurses in Indiana help just 4 people quit smoking per year, you could reach over 400,000 smokers, over a third of the million-plus smokers in your state. You can make a big difference in your patients' lives. We know that the 2.5 million nurses, if they get adequate training, can have the confidence and skills to intervene with patients. And we hope that this program has helped you on that journey. Now, this is what the tobaccofreenurses.org webpage will look like. Again, we continue to update this, so it might look a little differently when you go on. But right here, this is the HelpingSmokers.Quit tab. You have to type in HSQ, and that will link you directly to the page with California, West Virginia, and Indiana. Now, on this page, you are going to find other important material. We have a link to the Treating Tobacco Use and Dependence Clinical Practice Guidelines. We have a link to frequently asked questions, which we update as we have conversation with nurses around the country. It also has a link where you can email us directly if you have any questions. And you can also click on Indiana and find out the specific resources for your state. So I'd like to thank you very much for your attention today. Please know that this is not the end of our contact with the nurses in Indiana. Many of you participated in our pre-conference survey on the web where we asked you some information about your interventions with patients. We also will be doing a follow-up survey, and even those nurses who did not participate in the initial survey will have an opportunity to participate in the follow-up survey. And then 6 months after that follow-up survey, we'll send you another questionnaire. We're going to be having conversations with the clinical nursing officer at your facility because we want to find out what are some of the other system things that we can do, such as prompts with electronic medical records, that can really help make a difference. Stella, do you have any comments before we sign off?
No, just thank you, everybody. And again, if you do have questions, feel free to either check on our website or email us directly, and we'll do our best to facilitate your implementation of these interventions with the patients. Thank you very much.
Okay, thank you. Bye-bye.